Thank you very much. And in my presentation, I want to share our knowledge about leisure in minimally invasive neurosurgery, about our experience. I'm not at first in Pakistan, maybe fifth time maybe now. In Pakistan, so I have a lot of friends here, good relations and a lot of collaborations, not only in neurosurgery and also for education and scientists and so on. Thank you very much again for our friends. I'm from Tumen City, and in Tumen City, in 2011, 2010, we create the Federal Center of Neurosurgery, a special center only for neurosurgery. And he located in Tumen City, very beautiful city in the West Side area. And not a lot of, but some neurosurgeons from Pakistan has training in this place. What about laser? Laser is a very interesting device with a lot of possibilities, not only in neurosurgery. You see, in a lot of fields of medicine, even in neurosurgery, is very useful. And you see the developed also the lasers develop very strongly now, and you see how its possibility of the lasers change during the wave of during the length of the wave. And you see now one of the best laser now for the surgery is the thulium laser, because the length of the wave is quite long. So why this thulium laser has the unique possibilities for the blind stopper and so on, for example. So why we have in our neurosurgical center, we have some evolution for neurosurgery. So we start from standard surgery, and just now have possibility for the minimally invasive surgery. So we have keyhole craniotomy, endoscopic, lot of endoscopic surgery, and now we have possibility of laser, stereotaxy. And now we combine it all together, and we have possibility for develop the minimally invasive neurosurgery. Of course, for this kind of surgery, we need some special equipment. For example, thulium laser. You see our laser from our center, and we see this kind of fiber with the possibility of action by the null, 90 degrees, and so on. You see the 272 and this size, and you see how we use this laser inside of endoscope. This is, for example, standard water endoscope. We put not only a standard forceps, for example, scissors inside, but also laser fiber is possible to put inside of the endoscope. It creates a really minimally invasive surgery. And this is a very special endoscope. This is our endoscope. We create with a combination of the Storz company, the semi-rigid, very thin endoscope, but with all possibility of standard endoscope. And you see in this slide how we put inside the laser also possible put inside. Also sometimes very useful because it's really minimally invasive surgeries for orientation. We have some ICT hybrid operation with possibility of navigation in real time. Sometimes it's very automatic registration is possible here, and sometimes it's possible, especially when you drainage the CSF. Of course, the minimally invasive neurosurgery needs a long way. It's not easy surgery, so in our place we have unique possibility for the training neurosurgeon for this kind of surgery. And you see our possibility for this is we have a full body cadaver labs, microsurgery labs, we have the animal wet lab, for example, stimulation free lab, and so on. And a lot of workshop every year we create and perform for young residents, and not only for young, also for advanced courses we also have. We have long way for the laser neurosurgery, and in this slide I want to share our way. So at first we have some experimental work because laser for us is new tool, and we must understand how use this safely use this device for the in neurosurgery. Another one is very important anatomical knowledge, because mainly we use this device for some functional neurosurgery. For epilepsy surgery, for example, and you must know very well the white matte dissection, just for disconnection surgery, for example. So why we have a lot of clinical dissection, for example, and so on. And only after neurosurgeon is so experienced, so we start really clinical work, like minimally flashes neurosurgery. This is our way. Experimental work, just we put by the rats, and our goal is to study the effect of the two-lymph laser on the subcortical tissue on the rat brain. Because I'm a little bit limited in time, so I shortly just to show you. So this is the rat, MRI, and so on. And we have some histological examination, MRI examination, 1, 3, 7, 30 days, and for us it's possible to examine how the cyst formed after we use lesion. And we understand what is the, after lesion ablation is formed the non-true cyst. You see our data. This is our data from histology, 1, 7, and 30 days, and so on. So, and you see at the finish stage, you see the formation. So again, a lot of dissection also we create just for laser surgery, and this is the example in our lab. This is our residency work, just to understand the pathway. And this is I want to show some examples about laser surgery. So in this slide, you must understand how we work. So we have microsurgery and endoscopy at first, just to have experience about the lesion. So combination, for example, microsurgical cardiectomy and laser endoscopic commissurotomy done. Another very great possibility to use endoscopy for the lesion. This is, for example, endoscopic laser disconnection of the hypothalamic hamartoma is possible. We have experience. Endoscopic laser fornicotomy, hypercarpalotomy, and amygdalotomy is possible in one session. And for example, endoscopic laser callosotomy and the anterior and posterior commissurotomy was done. Another, after we have this experience, we improve our technology and we go another level. Another level is the stereotactic surgery under eye MRI. So stereotactic laser disconnection of the focal cortical dysplasia is possible. Stereotactic laser disconnection of the hypothalamic hamartoma is possible. Stereotactic laser vaporization of the temporal encephalocele is a really unique also possibility we have also. And after that, we go another level, and this is the stereotactic and endoscopy combination. So stereotactic laser amygdalotomy and endoscopic laser fornicotomy is possible. Stereotactic laser callosotomy and endoscopic anterior and posterior commissurotomy is possible. And the stereotactic laser callosotomy, amygdalotomy, and endoscopic laser anterior posterior commissurotomy is possible. So a lot of combination. Use laser in the neurosurgery. This is not all. This is not all. This is only some example. In practice, most widely possibility. So as a case one, so you see our experience about endoscopic laser fornicotomy, hypercarpalotomy, amygdalotomy on the right under neuronavigation control. You see the typical epilepsy specimen on this side, and we don't reject temporal lobe. Don't reject. We use our minimally invasive surgery. This is preoperative planning, and we plan go to the temporal horn from the atrium, from the posterior approach. You see, before by the neuronavigation pointer we create some track here because it's a very narrow temporal horn. At first, calibration of our neuroendoscope we create with the Storz company. You see, with possibility of navigation. And just put laser inside of the endoscope. You see our endoscope and laser and laser inside. This is the tip. It's very thin endoscope, very thin, with the laser inside. And this is how we create the surgery. We go by the track. This is the track in the brain. We created before by the navigation tool, but now we are in the atrium. This is the choroid plexus in the atrium, the main landmark. And when we go to the temporal horn, you see our hand, how we work, and this is like how we work in the lab. We go inside the temporal horn, and now we see also remember we see hypocamp and the endoscopic visualization. And now we reach the amygdala, and this is a little bit calculates the choroid plexus because obscure our view. So we diminish, and now we diminish calculations the choroid plexus just about to increase the volume of the ventricle. We go inside ventricle again, and now we reach the amygdala and we vaporize the amygdala. You see? Now we destroy amygdala by the laser. And after we go back, this is hippocamp and destroy the hippocamp, you see? Under control. It's very precise, very really minimally invasive surgery. Under the visual control. Just cut hippocamp and destroy hippocamp. And after that, we found the fornix and cut fornix also. So in this kind of surgery, not necessarily temporal lobotomy. Just only one punctus tract, just twist drill technique. It's really minimally invasive technology. Now we check what we do. So no hemorrhage. This amygdala destroyed, and so on. This is 1 year follow-up, seizure-free, no seizure. Angel 1. And this is a track, destroyed amygdala, and so on. And no craniotomy, only twist drill technique, 1 millimeter bar hole, not bar hole, twist drill. Another case is this connection of focal cortical dysplasia. You see the focal cortical dysplasia here, resistance form, and now we create a lot of planning before. You see here. It's our equipment in our operation room. And now we start to at first dissection, to must understand how it's created. For example, inferior front occipital fasciculus and so on. Corticopontid cerebellar pathways, uncinate, a lot of finger dissection before, just to understand how to disconnect. And after that, under interpretive control, MRI control, this is our power and energy joule. All total approximately 100 joule we used for each trajectory. And you see the variable gate and brain lab navigation tools we used for this kind of surgery. And result, not bad. You see the MRI 3 days after. This is 5 days after dissection. And after stereotactic laser callosotomy, we use endoscope and laser just for additional anterior and posterior commissurotomy for complete callosotomy. You see? This is only first step, stereotaxy. Second step is we put inside endoscope and make anterior and posterior commissurotomy inside of the third ventricle by the laser. Really minimally invasive. Also, access point, same, 1 point, just twist drill. No craniotomy. It's really minimally invasive technology. I create anterior, at first is anterior, this is anterior, and then we go posterior part of third ventricle, and this is posterior commissure, and now we create posterior. This is the laser posterior commissure aqueduct, and also cut the commissure by endoscopy. Really minimally invasive. Another case is hypothalamic hamartoma. It's really difficult case. This case before treated in Japan, but no success. So come to our place, and we make this connection under direct visualization by endoscope. Trajectory, because very narrow ventricle, for example. Trajectory, foramen, so entry point, checking point, so all points. And now it's the surgery. We put endoscope inside the lateral ventricle. You see the monro. It's very narrow monro, but it doesn't matter for our endoscope. It's very thin. And this is the third ventricle. And this is the hamartoma inside the third ventricle. And now I start to disconnect from the lateral wall by the laser. See the laser, and I disconnect by the laser from the lateral ventricle, third ventricle, and the visual control, without craniotomy. Only twist drill technology. It's really minimally invasive. Like this, we shorten time, so quickly, fastly. This is after vaporization. You see, completely disconnect under direct visualization. 100% sure about this connection. This is after disconnection. You see, the seizure practically disappear. This is stereotactic disconnection, also possible. The same problem, but stereotaxia. You see the hamartoma inside. Use variogate, stereotaxia variogate, step by step. Put laser inside. This is disconnect. Another very interesting case is temporal encephalocele. Sometimes is the cause of the epilepsy. You see that all it's normal, but you see this small one, very small one. This is the cause of the epilepsy. If you disconnect here, no epilepsy, no seizure, but you must know about it. First my cases, I operate open. For open operations, you need big craniotomy. It's a lot of problem for the patient. So I start treat these patients by the minimally invasive technology. No craniotomy. So again, stereotaxia, variogate, step by step. Twist drill technology, you see no craniotomy, it's really minimally invasive. Put inside, intraoperatively MRI. We disconnect this encephalocele. This is our number of power of the lesion energy. This is our MRI. You see after operation, before small one. This is the laser track here, intraoperative MRI, and this is after operation. The results 1 year after operation, injury 1, seizure free, no craniotomy. This is the place of the disconnection. It's really minimally invasive, no craniotomy. Also, not only functional neurosurgery, for example, another kind of neurosurgery is possible. For example, some cysts in the neurosurgery also possible to treat. For example, arachnoid cysts, a lot of arachnoid cysts we have, and experience also we have. So some examples is posterior fossa, for example. Before, after, this is surgery, how we create vaporization in so elongate place, because posterior fossa not easy for treatment, but with laser it's possible with minimally invasive possibility. You see, like this. You see like this. We create big hole, no problem, because laser is very precise, very precise. You don't afraid to damage the brainstem, for example, vessels, like this. Endoscopic also for the colloids also is possible. Endoscopic laser using. You is our experience about difficult case, about callosotomy, colloid cyst removal, sorry. Yeah, we should remove the cyst, but and now the bleeding, how to stop bleeding? Because the fornix, something like that, so it's very important, the precise stopping of bleeding. So only laser possibility, because I start by mechanically, by the Fogarty, not effective, you see? After Fogarty, bleeding. But structure around is very dangerous. So I use laser. You see the possibility of laser for stop bleeding. Very precise, very safe. Very precise. And big vessels is also possible if necessary. For example, big vein also possible to calculate. So laser is unique tool. You see also bleeding. Also fornix. It's really difficult by standard technique, but by the laser it's no problem. Very precise. No deficit after operation. Septum pellucidum, for example, also this is unique case. For example, septum pellucidum, cyst, you see, and tumor. Possible together, minimally invasive, without craniotomy. I start, open the cyst, big vaporization, without no problem. And then go to the tumor, you see the tumor, in one session. At first biopsy, and then vaporized tumor. Biopsy, also no craniotomy, really minimally invasive surgery. 3 drill technique. And after biopsy, the vaporization of the tumor. So why lasers have big advantages in the oncology surgery, neuro-oncology surgery also. So we use laser also in neuro-oncology, so laser ablation for the glial tumors, for metastasis, for meningioma matrix, keyhole chirurgy, tubular, minimally invasive 3D exoscope resection is possible, and photodynamic therapy is also possible. This is some example. For example, we use system tumor for the tumor in elongate area. You see the area, and this is elongate area. So only laser give us possibility to vaporize this tumor without any deficit after operation. This is the planning, precentral gyrus, motor area of the hand is very close. Corticospinal tract is very close. This is tumor. So we create some trajectory for the laser, and we measure to the corticospinal tract, some 10 millimeters. So we use laser. And the control at first biopsy, like this, and then vaporize the tumor. And after ablation, you see, tumor gone. After ablation, tumor gone. This is also a very interesting case. Not only endoscope we use. Sometimes in this big tumor, for example, and very vascular tumor, we use exoscope system. This is our equipment for this kind of surgery. It's not easy. You might use exoscope, ultrasound, some endoscopic equipment, and laser also. This is our experience with 3D exoscopy. At first we create trajectory, right trajectory, skin incision, because it's a really small child, so we must save the blood. Okay, this is okay. This is exoscope experience. This is a port. coagulation and then foramen Monroe. And now we use laser for the shrinking and vaporization of the tumor. Vaporization, and remove piece by piece, without any bleeding, without any problem. Control, after endoscopic control, total removal, no remnants. After operation is total removal. Another case, very interesting, Horiplex papilloma, also really minimal invasive surgery from posterior with drill technique. We create the trajectory before, go inside. You see the plexus. You see the tumor inside. This is, and also vaporized tumor by the laser without any risky, without any bleeding. Put inside the lesion. This is after operation, total removal. Okay, finished. Finished. This is photodynamic therapy. This is the last case, but okay, last case. This is photodynamic therapy. Yeah, that's very interesting. Yeah. I have very interesting tool, you see. Very interesting tool. Yeah, I'm completely freehand technique. This is for diagnostic. This is photodynamic therapy. This is open surgery. Okay. Okay. Well, this is our schedule for the next year for the young residents for training. Please welcome to my place. I open for collaboration. Thank you very much.